Hello everyone, am I audible and visible? Let me know, then we'll start. Okay, fine. I think I'm audible. Just a minute. Audible now. So, hello everyone, I'm myself Dr. Deepti Kare. I'm MD PhD Physiology and your educator for physiology. Okay. Now, so today we will discuss about properties of cardiac muscle. One of the property, important one that we are going to discuss, that is excitability. Okay. Before starting class, I just want to announce you that all my notes are available in soft copy as well as hard copy. To get the soft copy, you have to download the application Vesalius and you have to subscribe for the same to get soft copy. Link for that is given in the description box, and for hard copy you can order on Flipkart or Amazon. That is available in the form of a book, physiology notes, and link for that also is given in the description box. As well as if you have any query regarding application, regarding book, or any other regarding physiology, you can WhatsApp me. This is my WhatsApp number 78638226668. I will try to solve your queries as soon as possible. Okay, fine. So today we'll discuss about properties of cardiac muscle. Okay, which are the properties of cardiac muscle? Let us first enumerate all. One is excitability. Second is autorhythmicity. Third is rhythmicity. This is automatic rhythm. Okay. Then rhythmicity. Fourth, that is conductivity. These four are electrical properties. Then second, that is mechanical properties, which include contractility. Okay, one. Second is all or none law. Third is staircase effect. Fourth, refractory period. Okay, and summation. These are the all the properties of cardiac muscle. Fine. Now starting with first one, that is excitability. Any tissue, either muscle or nerve, that is excitable. Same way cardiac muscle are also excitable tissue. So whenever any stimulus is given, cardiac muscle gives response in the form of excitability. So it gives response by excitation. Okay, this excitability property that is different from electrocardiogram. Why? Because in electrocardiogram we are recording the change in the electrical events that is generated with each beat, and here electrodes are placed outside the heart. Okay, so in electrocardiogram, okay, this electrical responses, they are action potential, and mechanical responses which we are recording after electrical events, that are the series of events, that is your cardiac cycle. And this electrical events followed by mechanical events, that is known as excitation, contraction, coupling. Okay, now let us discuss about membrane potentials, starting with first resting membrane potential. What is resting membrane potential? It is potential difference across the membrane in resting state. Easy definition, that is potential difference across the membrane in resting state. Okay, in cardiac muscle fiber, resting membrane potential, that is about minus 90 millivolt. Okay, you can say what do you mean by minus 90 millivolt? That is negativity inside as compared to outside. So inside you can see, suppose this is one cardiac muscle, inside is negative, outside is positive. So this is minus 90 millivolt. Okay, because we are placing one electrode inside and other outside for recording. Now we come to action potential. What is action potential? Like other tissue, action potential in the cardiac muscle is defined as same. Whenever any stimulus is applied, threshold strength of stimulus is applied, there is change in the membrane potential. Series of changes, they occur within fraction of a second. That changes, they are action potential. Here in cardiac muscle, action potential duration is longer as compared to skeletal muscle. It has following phases. One, that is phase 0. Phase 0, that is phase of rapid depolarization. This one, rising phase. Then phase 1, slight repolarization. Initial rapid repolarization. Then comes phase 3, phase 2, that is plateau phase. This one. Okay, then phase 3, that is rapid repolarization, and phase 4, that is again resting state, polarized state. Okay, now we will discuss one by one, starting with phase 0, rapid depolarization. You can see here, this is depolarization. It is characterized by upstroke, means potential rises rapidly. This is the rapid depolarization. Okay, potential rises rapidly. It changes from minus 90 millivolt and it reaches to plus 20 to plus 30 millivolt. You can see. What do you mean by plus 20 to plus 30 millivolt? There is positivity inside in reference to outside. Okay, because of opening of sodium channels, inside starts getting positive, and this lasts for only 2 milliseconds, and which is followed by phase 1, that is rapid repolarization. Okay, here first rapid, then slow. Okay, this repolarization is short-lived, and that is self-limiting. Now, what are the ionic bases of this rapid depolarization or phase 0? They are, number one is, what are the ionic bases? Number one, there is opening of voltage gated sodium channels. Okay, and because of opening of sodium channels, you can say that there is influx of sodium ions inside the cell. So sodium ions, they enter inside the cell. That is one thing. Okay, and therefore membrane potential starts becoming positive. You can say that there is 100-fold increase in the permeability of sodium ions when stimulus is given. That is one cause. And when the potential reaches to minus 30 to minus 40 millivolt, here there is opening of calcium channels. Calcium channels, they open. Okay, and that is responsible for prolonged phase of depolarization, and depolarization we will discuss. Okay, for prolonged plateau phase. Fine. Now, second is phase 1. This is phase 0. This is phase 1. Phase 1 is rapid repolarization. Here, this is short lived. Okay, this is very short lived, and in this phase membrane potential falls from plus 30, you can see here, to minus 10, up to this. Okay, rapid fall in the membrane potential. What is the cause of rapid repolarization? That is because of closure of sodium channels. Now sodium channels, they get closed when the potential reaches to plus 30. And second thing is, potassium channels, they start open. Okay, opening of potassium channel permeability increases 5 folds, and because of opening of potassium channels, there is outflow of potassium because it is intracellular cation. So when potassium channel opens, along the gradient potassium ions, they move out, and when potassium ions, they move out, potential falls. Fine. Now phase 2, that is plateau phase. In this phase, you can see there is slow fall in the membrane potential. Okay, slowly, only to minus, up to minus 40 millivolt, not more than that. Okay, during this phase, cardiac muscle, you can say this is depolarized phase. Cardiac muscle is in depolarized state, and duration of this phase is about 100 to 200 milliseconds. Okay. Hmm? Now, what is the significance of this plateau phase? Cardiac muscle contraction, they are prolonged as compared to skeletal muscle because of this plateau phase. Cardiac muscle contraction is 5 to 15 times longer than skeletal muscle contraction, and the cause is plateau phase. Okay. Now, what are the ionic bases of this plateau phase? You can see here, this is plateau. Here there is inactivation of sodium channels. Sodium channels, they get inactivated because once the potential reaches to plus 30, sodium channels, they get inactivated. Okay, and second thing here, there is opening of sarcolemmal L type of calcium channels. Calcium channels, they get opened up. Okay, and there is potassium efflux, which is slow because of opening of this calcium channels. Potassium ions, they do not move fast. Fine. Next phase is phase 3. Here, this one, after plateau, we have rapid repolarization phase, complete or rapid repolarization phase. Here membrane potential falls rapidly, reaches to the resting state. Okay, what is the duration of this phase? That is about 50 milliseconds. And what is the ionic basis? Here now calcium channels, they get closed up. You can see here these are the various channels: sodium channels, potassium channels, calcium. Now you can see here during this phase, now your calcium channels, they start getting closed, and closure or inactivation of calcium and sodium channels, both this and this. And now potassium channels, this one, they get opened up, opening of potassium channels and rapid efflux of potassium ions. As I told you, because potassium is intracellular cation, so potassium ions, they move out. Okay, fine. Next is resting state. Again the resting state is achieved after, because of exit of the potassium ion. Ionic basis, that is resting state, is because of potassium current, resting potassium current, and sodium potassium pump. These two are the causes for resting state. Okay, in cardiac muscle, action potential is because of two channels. Okay, in skeletal muscle, action potential is because of only sodium channels. Here it is because of sodium channels, which are fast, as well as slow calcium channels. Fine. So difference between skeletal and cardiac muscle contraction, that is, there is opening of slow calcium channels, which are slow to open and remains open for long period of time. Okay, several tenth of second. And during this phase, calcium ions, they enter, and that results in plateau phase. In skeletal muscle, calcium ions, they come out of the sarcoplasmic reticulum only, but in cardiac muscle, calcium ions, they are coming from the extracellular fluid also through TTPs. Okay, now another difference, functional difference between cardiac and skeletal muscle contraction, that prolonged plateau phase, that is number one, is, as we have discussed initially, immediately after the onset of depolarization and action potential, there is five-fold decreased permeability of the potassium channels. You can see here, this decreases. Okay, so potassium ions cannot move out. Okay, that is responsible for this plateau phase, one cause. Second, this potassium permeability decreases because of calcium channels. You can see here, because calcium channels, they remain open. Now this calcium channels will not allow the potassium ions to move out. So cause for decreased potassium permeability may be excess calcium influx. Calcium channels, they decrease the permeability of potassium ions, and when potassium ion permeability decreases, you can say that that results in this plateau phase. It will not allow this repolarization. Fine. Now closure of calcium channels. Now at the end of plateau phase, calcium channels, they close. So what happens? There is increased membrane permeability for potassium ion, and then there is repolarization state. Okay, now duration of action potential in cardiac muscle, when heart rate is 75, duration of action potential is about 250 milliseconds. Okay, depolarization and plateau is 200 milliseconds, and repolarization is 50 milliseconds. Okay, and if the heart rate increases, this phase decreases. Suppose heart rate becomes double, this is half. Around 150 milliseconds. So duration of action potential is inversely proportional to heart rate. Fine. Again, you can see this is the action potential. This action potential spreads through gap junction. As we have already discussed, there are functional syncytium, atria, and ventricular syncytium. So action potential passes from one cell to another cell. Now, calcium induced calcium release. Here what happens when there is depolarization? You can see here L type of calcium channels, they open, so calcium ions, they enter from extracellular fluid, okay, inside the cell, and when calcium ion enters, they cause opening of this ryanodine receptor, this green one. Okay, and these ryanodine receptors are present on the sarcoplasmic reticulum. So from that calcium ions enter. So you can say that calcium induced calcium release. Okay, so calcium here, that causes calcium release. Fine. Now next is this calcium ions, they are responsible for the contraction. Afterwards, what happens after the contraction is over? There are other channels, sarca, as smooth endoplasmic reticulum calcium channel, that causes back entry of calcium into the sarcoplasmic reticulum. And when these channels they get opened up, there is relaxation of cardiac muscle. Why relaxation of cardiac muscle? Because now calcium ions are not available. Fine. So this is calcium induced calcium release. Next is relaxation of cardiac muscle. As we have discussed, when there is opening of the sarca channel, calcium enters in the sarcoplasmic reticulum, calcium concentration decreases and relaxation. Another important way is this calcium ions, they go out of the cell by counter transport. Sodium enters here and calcium exits out. And for that, how the gradient is produced? By sodium potassium pump. So when sodium potassium pump is active, 3 sodium ions are pumped outside, 2 potassium ions are pumped inside. Okay, so inside sodium concentration decreases, so the gradient is created. So inside sodium enters and calcium moves out. Okay, so this is secondary active transport. Now applied aspect here is some drug is used, digitalis as well as other glycosides. They increase calcium concentration. How? They block this sodium potassium pump. So sodium concentration sodium concentration increases here, and calcium sodium counter transport is not present. So calcium concentration inside the cell increases, and therefore myocardial contractility increases. And this is used in patients of congestive cardiac failure. Congestive cardiac failure. Fine. So this is about relaxation of cardiac muscle. Now factors affecting membrane potential. One, that is acetylcholine or parasympathetic stimulation like vagus stimulation. This acts by muscarinic receptor. On the neuromuscular junction, this acts by nicotinic receptors. Okay, here they are muscarinic receptors and they decrease heart rate. That is known as negative chronotropic effect. As chronotropic, chronology, that is heart rate. So chronotropic effect, negative means decrease. What is the mechanism of action here? Because acetylcholine opens potassium channel. So what happens? Potassium ions, they move out and there is decrease in the resting membrane potential and there is hyperpolarization. And hyperpolarization, that results in decrease in the membrane potential and decrease in the heart rate. Same way, force of contraction also decreases here, negative inotropic effect. Here what happens, acetylcholine decreases intracellular cyclic AMP and also decreases calcium ions. So force of contraction decreases. Other factor is epinephrine or sympathetic stimulation that acts through beta 1 adrenergic receptors. Important one. Effects: increases heart rate. Mechanism of action: epinephrine increases calcium entry, calcium influx. So permeability of calcium and potassium ions, that is affected and increase in the heart rate, and also it increases force of contraction by increasing calcium level. Effect of temperature: with increase in the body temperature, heart rate increases, force of contraction increases, and decreased temperature decreases both. Various ions, sodium ions, decrease in the sodium ion has no effect on cardiac contraction, but if sodium ions they increase in extracellular fluid, what happens? There is decrease in the myocardial contractility. Why decrease in the myocardial contractility? Because sodium ions they compete with calcium ions. So now calcium ion cannot work, so sodium ions they are working and their action is less, so they decrease myocardial contractility. Okay, then effect of potassium ions: hyperkalemia means potassium concentration outside the cell increases. So what happens when potassium outside cell increases? Resting membrane potential decreases. So you can say that there is hyperpolarization. So membrane potential may not reach to resting state, and there is no depolarization. And that results in decrease in the conductivity, also decrease in the excitability. That results in heart block and decrease in the heart rate. That results in dilated and flaccid heart, and heart stops in diastole. These are all things you have to remember. Another, so one is there is defective conduction, heart stops in diastole, and third thing is magnitude of action potential is also reduced, strength of the myocardial contraction is also reduced, and this is found in cases of kidney failure when potassium concentration increases, because kidneys cannot excrete potassium ions. Okay, calcium ions, when calcium concentration increases, definitely heart rate and myocardial contractility increases, and calcium concentration decreases, heart rate and myocardial contractility decreases. Applied aspect here is in cases of coronary artery disease, calcium channel blockers are given. They block the calcium channels. So you can say that workload on the heart is reduced. Workload on the heart is decreased. Okay, so this is all about property excitability. For one of the property, next we will discuss, that is automaticity. Okay, and autorhythmicity. Again, the same thing. If you wish to get soft copies of my all lectures notes, that is available on the application Basilius. You can download and subscribe. Hard copy that is present, that is available in book, that is physiology notes. A link for all that is given in description box, as well as you can join me on my WhatsApp number. We have a WhatsApp group of physiology notes also. The WhatsApp number is 78638222668. Okay, thank you so much. If you like my video, you can like it, you can share with all your friends, and you can subscribe our channel. Thank you so much.